Incidences of cancer are on the rise in this country. According to the 2022 Indian Council of Medical Research study, 1 in 9 Indians is likely to develop cancer in their lifetime. Cancer treatment, however, has seen significant advancements. We're joined in studio by a distinguished panel of domain experts to tell us about the signs and symptoms of cancer, the importance of early diagnosis, and the treatment options available in our country. We welcome you to our special feature, I.O., a public awareness initiative by MSD Pharmaceuticals. We have with us Dr. Ankur Bail, Senior Director, Medical Oncology, Fortis Memorial Research Institute, Gurgaon; Dr. Vikas Goswami, Director, Medical Oncology, Max Super Specialty Hospital, Saket; and Dr. Rajat Bajaj, Director, Medical Oncology, Fortis Hospital, Noida. Thank you so much for taking the time to join us in studio, gentlemen.
Yeah, thank you.
And Dr. Ankur, I'd love to kick off the conversation with you. Walk us through some of the leading or most common telltale signs or symptoms of cancer, sir.
Pooja, so most common seen and what are recommended telltale signs are any lump in any part of the body, any change in voice, cough with the blood, vomiting with the blood, any discharge, a bloody discharge from vagina or any from stool or urinary orifice, or you're losing weight and you're having a fever, which is a chronic fever. All are telltale signs of cancer, but what I would emphasize is that any chronic symptom, a back pain which is not going, pain abdomen which is not going, so any chronic symptom,
Right.
It's the duty of a general practitioner sitting anywhere in a village, town, city, metro city, or wherever in the world. Cancer should be one of the differential diagnoses when it comes to any chronic symptom, I would say more than 4 to 5 weeks.
So how critical is early detection in the context of positive patient outcomes?
So that's the most important part in our field, that patients who come to us, patient comes to my clinic, so majority of them are in stage 3 and 4. But since I practice in Gurgaon, we have been seen in last 4-5 years, particularly that women are coming with stage 1 breast cancer. The most important reason is not that they are educated. The most important reason is that the community around them advocates screening. If the population emphasizes that screening should be done, age-specific, sex-specific screening is done, then the incidence of stage 1 cancer, stage 2 cancer increases in the community. And we all know that cancer is curable if it is being detected in stage 1 and 2. Above 80-90%, stage 3, stage 4. Stage 3 is just 40-50% control, and stage 4 is not curable. So we have to bridge this gap. We have to upside the pyramid.
Absolutely.
That we need to detect these cancer in stage 1 and stage 2, and only screening can do this.
When we think of standard of care treatment modalities in the context of cancer, what comes to mind is radiation, chemotherapy, and surgery, right? So help us differentiate between these different modalities, firstly, and what sort of situation or scenario typically calls for which treatment plan?
Cancer treatment primarily involves surgery, it involves radiation, and it involves medicines. Now, chemotherapies are part of a group called as medicines. So the treatment primarily depends upon the stage.
Sure.
Stage 1 is the early stage cancer, and in stage 1 we usually give surgeries. In stage 2 and 3, the usual treatment modalities, surgery combined with chemotherapies or radiation therapies. And in stage 4, usually the surgery is not the modality of treatment. Now, the basis of this is that surgery physically removes the disease.
Right.
Chemotherapies or other medicines ensure a relapse doesn't happen, because they treat something called as micrometastasis. And the second aspect of chemotherapies is to ensure a good surgery. Imagine a situation where the tumor is too big to be removed physically.
Right.
Then we usually give medicines or chemotherapies first to ensure a reduction in size of the tumor, and then the surgery is done. Radiation usually is to ensure that a relapse doesn't happen at the site of surgery. So they all have different rules. Usually if the disease crosses stage 4, then surgery is not the part of treatment anymore. So to answer your question precisely, which modality will be given when is usually decided by the stage of the disease.
Dr. Rajat, above and beyond what you've heard our prior two panelists talk about, what we also come to is advanced treatment options, right? So what exactly does that terminology stand for? What does it connote, and how does it differ from what we just heard Dr. Vikas describe?
Dr. Vikas said that there are treatment options which are available for cancer, from the very proverbial surgery which used to happen, say, about 30-40 years back also,
Sure.
which was the use of a knife, and then came in the technique of radiation, where we give the radiation rays to the patient
Right.
to not let the micrometastasis actually blossom in future, and then came in the chemotherapy. When we talk about the advanced versions of treatment, we have the advanced versions of chemotherapy, and we have the advanced versions of a lot of other treatment options, especially pertaining to medical oncology, which is immunotherapy. There is a term called antibody drug conjugates, and there is a term called targeted therapies. And then now there is a coming up of CAR T-cell therapies also. Why these are called advanced techniques is because they don't really make use of how the mechanism of action of chemotherapy used to be. Chemotherapy is a chemical which is made by certain derivatives, and it is injected into the body, and it kills the cancer cells for sure, but it actually has an impact on the normal cells as well. An expert oncologist or a medical oncologist knows how to deal with the so-called adverse effects which are going to happen, and that is how we titrate the doses that, when we are giving, and then we give some injections to mitigate the adverse effects of chemotherapy.
Got it.
But then these advanced techniques that we are talking about, these advanced techniques would be different in terms of their mechanism. So how they work is that they don't really exactly try and kill the cancer cells with the chemical effect of it, but they increase the immunity of the body. Suppose I'm talking about immunotherapy. What they do is that there are certain security guards of the body.
Right.
These security guards are the ones like the T helper cells or the memory T cells, which actually are suppressed the moment cancer enters into the body. And these security guards, they are not actually able to solve their purpose of killing the intruders, which is the cancer cells. Now this immunotherapy is again an injection which is injected into the veins. What it will do is that it will give more power to these security guards to actually come out of their slumber and kill these cells which have actually come into the body, and that is how it works. So what it does is that it tries to actually go against the cancer cells and not do too much of damage to the normal cells.
Sure.
And that is how the tolerability or the tolerance to the treatment it improves.
Okay, well, I think that's very helpful. And since you brought up immunotherapy, and my next question is to you, Dr. Ankur, June incidentally marks Cancer Immunotherapy Awareness Month every year. Right? So walk us through immunotherapy in perhaps as layman language as possible, and what are the sort of immunotherapies that patients in this country can currently avail?
So immunotherapy is I would say, a new weapon in the armamentarium of an oncologist, and our patient deserves to live longer,
Sure.
which we say quantity,
Right.
and our patient deserves to have a good quality of life. So prior to the era of this modern medicine, which is targeted therapy and immunotherapy, our whole emphasis was on chemotherapy. So chemotherapy causes lots of side effects in the form of being sick, lots of vomiting, alopecia, the whole structure of the patient changes.
Right.
We can give chemotherapy to a certain extent into anybody, like 4 cycles, 6 cycles, or 8 cycles.
Sure.
So now we oncologists have an appetite that our patients should improve and they should live longer. So these new class of drug are given often with chemotherapy, and then they are used as a maintenance therapy. Once you have done, suppose in a stage 4 disease, you have done 6 rounds of chemotherapy with immunotherapy, and if the patient has certain characteristics, look, all patients can't be given immunotherapy. If the patient has certain characteristics in the tumor, then these patients can be given immunotherapy as a maintenance one. Since this immunotherapy doesn't have much side effect as compared to chemotherapy, so the tolerance to a patient, they can go to their office, they can take their lectures, drive a car. So many of our patients just walk in and they drive their car and they can go back to their home after taking immunotherapy.
Right.
So this is a change which oncology patients are perceiving. They are costly drugs, but yes, the quality of life, and there are lots of studies which have proved that if patient takes immunotherapy, his survival, what we called in our technical term is overall survival of a patient increases, his disease-free survival, he remains disease-free for a longer time. So these are the class of drugs, to be very, in a simple language, they are injected intravenously once in 15 days or 21 days, depending upon the kind of immunotherapy we are using.
Sure.
So they enhance your immune system. It means my house is a porous, I'm getting gates in my house so
Right.
that the thief cannot enter.
Sure.
So they enhance their own immune system, they activate their immune system, and this enhanced immunity kills the cancer cells. So this is a different ball game, and millions of patients are actually enjoying these drugs, and they're living and they're back to normalcy. And so the aim of the whole panel and the whole medical oncology department is to increase quality, quantity, and make this disease a chronic disease, as our diabetes are going in our community, as our chronic vascular disease are going, chronic kidney disease. So cancer can be made chronic without disturbing the quality of life with these class of drugs. And it is given across all solid organ cancer. I could not recall any organ in which immunotherapy can't be given, except pancreatic cancer and few other cancers. All cancers in our body, we have all the trials, all the studies, all the guidelines, whichever we follow, they have incorporated immunotherapy. It's a paradigm shift. If I see when I was a trainee, when I was practicing 10 years down the line, and now my practice has totally changed. Very proudly, we say that around 50-60% of our patients are on immunotherapy, and the number of occupancy in our hospital and our daycare are increasing because of this modality.
Very heartening to hear. And you touched on the side effects, and I will come to you once again, Dr. Rajat. What should a patient who's receiving immunotherapy expect by way of side effects? You could give us a detailed overview.
So immunotherapy, like we said, is an advanced technique, and we've been using it along with chemotherapy or in isolation as well. We all know that when we talk about newer modalities of treatment, we are absolutely enthralled with the fact that it is giving new hope to our patients. But as a caregiver, every patient has the right to ask the doctor as to what are the possible side effects of a new treatment if I'm going in for my patient. These side effects are certainly there with immunotherapy. They are different from what they are with chemotherapy. They are lesser than what they are with chemotherapy, but they are there. Now, how do they actually come up? The mechanism is that the immune system activation, which the immunotherapy actually thrives on when it is talking about the mechanism of action, is actually the reason for side effects as well in some of the patients. They are not going to happen in all like it is with chemotherapy, but they can happen, and it is because of the immune system activation. So they can range from a very innocuous skin rash to some patients developing some sort of diarrhea. There can be grades of diarrhea. Some patients can develop jaundice, which we call as hepatitis, or some patients can develop pituitary dysfunction or suppression of the pituitary gland, which is there inside our brain, which is leading to a reduction in the hormone levels, which can be thyroid hormones or steroid hormones. Very importantly, these side effect profile is different for different patients. So sometimes we are asked in our OPD that a particular patient that I had seen had a particular side effect. So that patient may have had a different disease, a different immunotherapy may have been used, or just the genetic makeup or the predisposition to a particular drug may have been different for that particular patient. So every patient has to actually understand the possible side effects which can happen, what are the percentages that can actually be for these side effects, and one should not really see others and try to think that these can happen to them as well. So overall, immunotherapy is much well tolerated as compared to chemo, but certain side effects always are to be discussed with the patient.
It's time for a short break, but our special feature, I.O., a public awareness initiative by MSD Pharmaceuticals, continues on the other side. So don't go anywhere. Well, I want to build on some of these observations, because the fact of the matter remains that several myths, unfortunately, surround immunotherapy. So I want to take advantage of the caliber of this gathering to dispel some of those myths today. So the first myth is coming to you, Dr. Rajat. Immunotherapy and chemotherapy are one and the same. That is a leading myth. How do you respond to that?
No, so I would say that they are definitely different. They probably may be same just because one has to come to the daycare and get them infused, both of them. They are intravenous, products which are given through the vein. Patient has to lie down on the bed, take the therapy for some duration and go back in the evening. That is what I would say is the similarity.
Sure.
But then after that, whatever comes is actually putting both of these two things in a different basket altogether. So starting from the mechanism of action, I previously also said the mechanism of action for a chemotherapy is chemical going into the body, causing damage to the cancer cells for sure, which is intended, but an unintended damage to the normal cells can happen. Although we do know how to mitigate it, but still. But if we talk about immunotherapy, it is activating our immune system, the memory T cells, and that is how those cells are actually being strengthened to fight the intruders, which are cancer cells. The other difference between the two is that these chemotherapies can be given for only a shorter duration, can be limited duration of 3 to 4 to 6 cycles, but immunotherapy can be given for a long duration. In fact, it is given so that durability effect of immunotherapy comes. Immunotherapy starts to take its effect slow in the body, but it is mostly a durable effect. So that also is a major difference. Thirdly, of course, the cost. Chemotherapy can have a certain cost. Immunotherapy comes with a little higher cost than what a chemotherapy would, but still now with a lot of initiatives done by a lot of companies in our country, the cost has come down and it is manageable. So they are certainly different. An oncologist can definitely discuss the different aspects of it with the patient. Patient can actually pose questions, and they do that in our practice very commonly. And we are happy to tell them that whether a treatment plan can incorporate immunotherapy or not.
And coming to you now, Dr. Vikas, another leading myth is that the side effects of immunotherapy are just as bad as those of chemotherapy. Your response?
Immunotherapies are part of something called as targeted therapies. Now, the meaning of this is that they only target the cancer cells and they spare the normal cells. So by virtue of this, see, the side effects happen when the bad cells die and the good cells die.
Right.
Good cells cause side effects. For example, hair loss, ulcer in the mouth. If we see a whole plethora of side effects in chemotherapy, in immunotherapy usually the spectrum is much more limited. Usually, like has been said, is restricted to skin rashes or maybe diarrhea, mild cough. Now in one odd case, the same symptoms can be very severe.
Sure.
Nobody can say which one would be those, but a word of caution is that usually those patients who have some autoimmune diseases, who, let's say a kidney transplant patient, such kind of patients are usually not encouraged to take immunotherapies.
I see.
And treat cancer like a chronic disease.
Another leading myth is that immunotherapy is to be used only as a last resort.
Yes, it's right statement that we used to give immunotherapy once chemotherapy fails as a second line or a third line. But now across all cancers and across all guidelines of the world, if the specific biomarker, if the tumor has specific biomarker as a specific indication, we oncologists are tempted to use immunotherapy upfront with chemotherapy many times in early cancers, early breast cancer, early lung cancer. So, and we try to, so as Dr. Vikas says, that we shrink tumor with chemotherapy. Now we shrink tumor with chemotherapy and immunotherapy, make it operable, then give later immunotherapy. So it's a big myth that immunotherapy are being used once chemotherapy fails. So now it's an synchronized treatment where both chemo and immuno are given upfront, and then chemotherapy is waived off, and then immunotherapy is continued as a maintenance therapy so that our patient lives longer.
Well, into my next myth, which I'll pose to you now, Dr. Vikas. And another leading myth here around immunotherapy is that it can only be used in the context of certain types of cancer. Is there any truth to that?
Initially, the indications were quite restricted, but of lately, practically, like has already been mentioned, practically from head to toe, all cancers, we use immunotherapy. There are certain guidelines how to use it. We can't use it like a panache, like one size fits all.
Right.
There are some tests. If the patient qualifies for those tests, then certainly it can be used in any cancer. Some cancers are agnostic, that means we don't need to do those tests. But by and large, it's a myth that it can be only used in certain cancers. I would say any cancer immunotherapy can be used if the patient is qualifying those criteria.
Dr. Rajat, I'll come to you with our last myth, which is that immunotherapy in this country is, has limited availability, only in certain centers, pan-India. How do you respond to that?
No, certainly, I think it is a big myth. Immunotherapy has been around for over 5 years now. In the initial years, probably that was true, but then now we're talking about it in 2025. It is very widely available, thanks to the multinational companies who have brought this actually to the fore in India. It is available. It is very much accessible. It is now affordable. There was a time when it used to be enormous in cost. Now the cost has come down significantly, as all the panelists have already discussed. So it has got a lot of indications, and one should actually discuss these options with the patients and actually use them in a judicious way. The availability doesn't mean that we will use them in all, but the availability certainly means that we will give it as an option to all the patients who would want to use it to actually make the treatment plan the best suited for them, and that treatment plan can actually give them the most durable sort of treatment that we are looking at. And immunotherapy is nowadays not only in stage 4, which it used to be. It has come into the early stages, and it has come into the early stages for all good. What it is now letting us do is that it is the best to not let the patient progress from an early stage to an advanced stage.
Sure.
That will be the best, and that is how we are actually curing the disease. We should discuss this with our patients for sure and give them the best viable option for the treatment plan.
Well, Dr. Ankur, Dr. Vikas, Dr. Rajat, thank you for sharing so many personal and professional anecdotes from your own journey. They make the conversation all the more relatable, and we salute everything that you do on a daily basis to combat cancer in this country, and we wish you all the continued success, gentlemen.
Thank you so much.
Thank you.